And so the easy thing to do is just to look at the patient's face, and there's 7 things that you can feel or see. It's not difficult. You look for the crest. You feel for the crest at the eyebrow. You feel for the orbital rim. These are things you feel with your fingers. You don't have to do x-rays on every patient. You feel for where the bone ends and the cheek, because if you can inject on bone, you will, but here you're going to inject on the teeth. There's nothing there. You look for the piriform fossa at the base of the nose, because that's a great place to inject patients, but the most dangerous. And I'll explain to you how you avoid danger there. And then you're going to feel for the corner of the jaw, because as women age, they lose that corner, and it would be nice to recreate a little corner there. So those are 5 things. 1, 2, 3, 4, 5. And then you're going to look at the patient and look right in the eyes. You're going to look at their eyes, and you're going to see where the color of the eye is. The iris. The inside and the outside of the iris will tell you where the arteries are on the face. Simple as that. In every patient. And you'll have them bite and feel for the masseter, because right in front of the masseter, where you feel the edge, is where the main artery of the face comes in. And that's it. And that will define zones that will tell you, do I inject on bone, or do I inject into the skin, or do I inject into subcutaneous tissue? Upper face. Remember, I told you feel for things on the face. With the upper face, you feel for the orbital rim here, and just above it at the eyebrow, you'll feel a speed bump, like that. That little speed bump over here is the temporal crest. Black? Thank you. Okay? The temporal crest is right here. And there's one on the other side. Okay? This is now the forehead. This is now the temple. For the forehead, 2 major arteries that you have to worry about: supraorbital and supratrochlear. Supraorbital artery, you have the patient look straight ahead. Good. I won't touch her. You come at the medial iris and you make a little mark over here. Okay? You put your finger there. Bingo. She has a small notch. 80% of people have something you can feel as a notch. 20% don't have a notch. They have a hole and you can't feel it. But 100% of patients, it's at the medial iris. It's the most consistent finding in the face. Okay? Beautiful. And then what happens is the artery comes out of the skull, because it's the continuation of the eye artery, the ophthalmic artery, and it goes up the face like this. Is that showing? Yeah. Come in a little bit. Can we get in a little bit closer to her face? Can you zoom in a bit? Zoom, zoom. Whoa, that's the zoom. Wow, good, thank you. We can come out just a bit, okay? Just a little bit out, maybe, if we can. Okay, it's good enough. All right. I'll stand behind her so I can try to draw this way. So that's the supraorbital artery. The supratrochlear artery. Supratrochlear artery isn't as consistent. It can be found anywhere from 8 to 12 millimeters inside or medial to that artery. How do you find it? You ask the patient to frown. I'm not sure if she can. Does she have Botox in? Let's find out. Can she? Oh, she can. Good. So frown again. Do you see this crease here? That crease where you frown, the closest one to the middle, is where the supratrochlear artery is, and it goes like that. Beautiful. Excellent. You have red? Yes. That's what I've been looking for. Oh, that's an even nicer color. Supraorbital, supratrochlear. I don't know whether these arteries are going like this, or maybe they're going at this angle, or maybe they're going at that angle, right? But I don't have to know. I just have to know how deep they are, okay? And the story is that for the first finger, for the first 1.5 centimeters over here, okay? For the first 1.5 centimeters, they're going from inside the head to the skin. They're going from deep to superficial. And I don't know how deep they are. Once they get to this point, they are no longer on bone, they're on the surface of the muscle, under the skin. There is pretty much nothing left on the bone over here. When we do forehead lifts, we can strip the forehead down in seconds because there's no major blood vessels on the periosteum. So, in this area, don't go under the skin with a needle. If you go under the skin with a needle, you can be inside an artery. From the skin to the surface of the bone is 2.4 millimeters of thickness. It's very thin. The artery is 1.8 on average. That leaves you 0.6 millimeters to find that space with the tip of your needle. There's nobody here who's that good an injector. It's impossible for 0.6 of a millimeter. So don't go under the skin there with a needle. If you want to inject into the skin for a glabellar line, that's fine, but you must be in the skin, not under it. For the rest of the forehead, you go deep on bone. Because even if you go through an artery deep on bone with cannula or needle, you're going to be under the galea, which is the sliding portion of the fascia, and you'll be through an artery and not in it. When you remove your needle, you might see blood, you put pressure, that's all. But you haven't been in the artery, you've been through it. So everything over here is deep, except for one thing. What color you got? White. Is this white?
Yes.
Okay. There's one artery and nerve that do this, that does this, like that. You see that? That one artery and nerve are the deep branch of the supraorbital nerve and artery because it wants to get to the back of the head over here to supply the head and the back. And if you touch it with a needle or cannula, the patient's not going to like it. They're going to say, ouch. And if you hurt them, they won't come back to see you. So if you have to inject for a forehead in this area, I suggest you inject here, put in a little more product with cannula or needle, whichever you've decided, and then push the product over with your thumb or your finger. So I would not inject here with a needle because I'm going to hurt her. So it's deep, 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 deep. Don't go under the skin here because you can blind her, and don't go under the skin here because you can hurt her. For the temple, it's even easier. For the temple, we have the superficial temporal artery. That's red. That's coming like this, and that's going to join one of these two arteries. So if you inject into this artery, it can go into the eye. The temple, which starts at the crest, has the temporalis muscle. The temporalis muscle is a muscle of chewing, not a muscle of expression, so it needs to generate a lot of force when it pulls up on the mandible. So it's attached to the bone here. If I try to pull her like this, I'll be able to do it, but it's hard. But if I'm holding on to the wall and I pull her, it's much easier. So the muscle is inserted into bone. Because it's stuck into the bone, the periosteum covering the bone and the fascia underneath the muscle here can't get under the muscle here. So they go over the top. And so you have muscle and then deep temporal fascia and then superficial temporal fascia. That's crazy. That's like having a sandwich where you put the meat on the plate and then you put two pieces of bread instead of putting the meat in between the two pieces of bread. But that's what we're going to use to our advantage, because if you inject 1 centimeter above the orbital rim, you go 1 centimeter up where the crest is, you can feel it, and 1 centimeter lateral, following the crest, so it looks like a little square. If you inject over here, the muscle is thin. There are no arteries down on bone, because the artery, red, that's deep over there, we've shown not to be closer than here. It's always 1.8 centimeters or more away from the orbital rim. Here there's no arteries. You go down to bone. You start to inject. Voluma, Volift, both excellent. They try to stand up because they're cohesive. The muscle here is very thin. They go right through the muscle fibers, and then they hit their head on the ceiling, which is the deep temporal fascia above the muscle, and they start to spread along the ceiling. And it will spread like this, like you put a pebble into a pond, into water. It stops here because it's fused. It stops here because it's fused. It can go all the way to the back of the head, so when you're injecting, and I'll show you the technique today, you put your finger over here to prevent it from going there, and then there's only one place that it can go. It will fill the whole temple. And you don't need much. Typically, I use 0.3, not a syringe. 1 injection point, 1 centimeter up, 1 centimeter over. Got it? Deep, 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 deep. Don't go here because you'll hurt her. Don't go under the skin here because you'll blind her. Go 1 centimeter up and 1 centimeter over on bone. You must feel bone. This is the technique that I use here. You can use cannula. For those who like to use cannula, you should be more superficial. A cannula has gone into the brain over here in Germany. You don't want to be deep. You want to be superficial, and anytime you use a cannula, and this is the number one trick I can give you, think of where the artery is, in which direction that it's going, okay? You can see the artery is going like this. Do not inject in the direction of an artery with the cannula, because if you do get into that artery, and you will, it will not come out. You're better off injecting against it, perpendicular to it. So never use a cannula this way in the forehead. Use a cannula this way. Never inject the temple this way with the cannula. Inject the temple this way. Start over the artery under the skin, where you're standing over the artery, and then move away from danger. Okay? Now we're going to do the lower face, and I have 10 minutes left. We're going to complete it. Watch. The carotid artery comes up, the external carotid, and gives off a branch called the facial artery. That facial artery branch wants to get into the face, but it can't because there's a big masseter muscle in the way. So you ask the patient to clench their teeth. This is the front portion of her masseter. I can feel it. Okay, thank you. And just in front of it, right there, and I'm going to put my finger there, I have her pulse. That's where the artery crosses into the face. And the second it comes into the face, it does this. Because it has to stretch like a spring. It's a thick artery. If she opened her mouth every time, it's okay, thank you. If every time she opened her mouth to chew, her face turned white because it was stretching the artery, it wouldn't look good. Blue. The vein is thin. So it doesn't have to do that, and the vein does this. It takes a straight course, like that. See that? And we'll find the vein inside the masseter. We find the artery in front of the masseter. But I don't know whether the artery turned left instead of right here. It's going like this, like so tortuous. But I don't have to know, Black. Because what I have to know is how deep are they? If the artery and vein are deep, where am I injecting? I heard somebody whisper superficial. If the artery and vein are superficial, where am I injecting? Deep. So this is why you feel for the bone over here. When you feel the bone, in this whole area of the face, the arteries and veins are deep. Because they're deep, they sit on the buccinator muscle. That's the muscle lining the inside of the mouth. They pass underneath risorius, zygomaticus major. They're passing under the muscles of facial expression. Okay? So, because they're deep, I'm injecting? Absolutely. Big S, superficial. And to make sure that I'm even more superficial, what I'm going to do is pull the skin out before I inject. Because if you pull the skin of your cheek, feel the inside of your mouth, the mucosa doesn't move. The artery stays deep, but what you've done is you've stretched the fat and skin, and you've given yourself more distance away from the artery. Okay? Good. I draw a line for the outside of the iris. This whole area of the cheek has an artery supplying it that's called red. Right, yes. That's called the transverse facial artery. It comes out like this below the zygoma. It gives a deep branch to the muscles here. Do I care? Why? Because I'm injecting superficial. But it gives a superficial branch that does this. It has branches like a tree. It arborizes. I can inject here, black, superficial or deep. I'll aspirate when I inject, but my risk is more for bruising in Caucasian country here. That's why I'm relaxed. Okay? You guys now have to deal with this, where she's flat, where we have to inject a little bit. That is tiger country. That's Asian country. Why? Red? Because there's a big tiger that lives there called the infraorbital artery. It doesn't come out at the rim. It comes out below the rim by about 5 to 8 millimeters and at the medial iris, or sometimes at the medial pupil or mid-pupil, which is why I put this line over here. That's a line I do not like to cross. I left myself a little extra distance. This is a forest full of lambs. This is a forest with a big tiger. Okay? So how do I treat this area? Very often I will inject here on bone, and I will push the product with my thumb because I can't hurt anything with my thumb, right? Or I will come in this direction with a cannula. I only use cannulas in this area. I do not like to use needles because I don't want to stick that tiger or he's going to bite me. Okay? And more importantly, what I do is when I use the cannula, I use the cannula from a lateral approach, never from below. Why? Here's the story. Let me get this straight here. Perfect. Look at the hole over here where the artery comes out. Do you see that? Right there? It's not coming out like this, straight out at you. It's coming out at an angle like this, 45 degrees down. And because of that, it has a little hat of bone here. So if you come from the side, you can't hit it. Look at the way it's shaped like a funnel here. If I come from below, I'm going to hit it every time. Do you see that? And we've seen people with terrible pain and problems here because people are going in with cannulas. So I want you to always have a lateral approach here. There's one area left on the face, and we have 3 minutes left. And that's this area right here. And that's called the piriform. If I inject her piriform, it will push that part of the face forward. Asians are naturally flat here. So it's a lovely thing to do because when you inject there, what it does is it narrows the nose like that, and look at the tip. The tip comes up. So you can actually affect the nose by injecting on the piriform, and not too much, 0.2. The problem is that this artery that goes back and forth sometimes lives right there. 20% of the time in Asians, 1 out of every 5 of you has your artery sitting in that triangle. 5% in Caucasians. Only 1 out of every 20 Caucasians has the artery there. Everybody else, it's to the outside. How do you know which is your patient? You don't. So the one thing you want to do is you want to inject where the artery isn't living. The artery is not in skin, so you can inject in skin. The artery is not on bone, so you can inject on bone. It's somewhere in the middle, so you do not inject with needle or cannula in the middle. This is where we're seeing too many accidents. And that artery, red, will connect very often with what we call the angular artery. So I'm injecting on skin, in skin, or on bone, but not in between. And when I inject down and away towards the opposite corner of the mouth, never up towards this artery. Okay? Deep, 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 deep. Don't go under the skin here because you can blind them. Don't go under the skin here because you're going to hurt her. 1 centimeter up, 1 centimeter over. Superficial. Superficial or deep. Cannula from a lateral approach, skin or bone.